Good evening, everyone, and welcome to the first webinar of 2024. We are so glad that you are here. My name is Alexa Jett with the ANCAN Foundation. Being your own best advocate means taking the information that you learned tonight to your care team. So we want to make sure that you know that this is not medical advice. We want to give a big thank you to our sponsors, Bayer, Sumitomo Biopharma, Foundation Medicine, Myriad Genetics, Janssen Johnson & Johnson, Telix, and Blue Earth Diagnostics. This webinar is super interactive. Please feel free to ask your questions at any time during the in the questions pane. And it is my honor and privilege to bring out not only one of our advisory board members and a beloved member of the ANCAN community, but also my friend too, John Antonucci.
All set, Alexa?
You're good to go.
Okay, very good. Hi, everybody. John Antonucci here from ANCAN. Almost all of you are familiar with ANCAN. ANCAN is a almost entirely volunteer organization, just a few part-time paid staff, designed and exists for the support and benefit of people with a number of serious diseases. All of our events and groups are free and drop-in. We have over 20 virtual groups monthly and provide accessible, inclusive, virtual peer-to-peer support for a number of different serious illnesses, as well as prostate cancer, which is the one that we're going to be focusing on tonight. And we reach out to people geographically, physically, to socially disadvantaged. It's all peer-to-peer, but as Alexa mentioned, we have a distinguished advisory board of professionals behind us. We're going to talk tonight about radionuclide Theranostics. Even since the time of my diagnosis several years ago, this is a new topic. And we're very lucky to have pretty much harnessed the power of radioactivity and refine the idea of specifically designed treatments for specific people, and also within each person, radiotherapeutics is designed with the intention of bringing a radioactive payload right up close and personal to our prostate cancer cells in order to destroy them and spare the rest of the tissue. It's a very complicated field and includes not only therapeutics, as I just mentioned, but diagnostics as well. We have some powerful diagnostic tools that we didn't have just a few years ago, and we're going to be hearing from some experts about how they work and what they can do for us. And hopefully we'll have our panelists also give some information about what might be coming down in the future. Telix is a very large Australian biopharmaceutical firm focused on the development of diagnostic and therapeutic radiopharmaceuticals of the kind that I just mentioned. Hopefully some of you are going to have a basic understanding of what that all means because of my recent newsletter write-up, but if not, I think our speakers are going to catch you up right from the beginning. Telix makes Illuccix, which some of you have already benefited from, and it has some really great things in the pipeline. Simone Layden is the Director of Global Patient Advocacy at Telix. She was just here in the States, participating in the ASCO GU meeting in San Francisco, but is now back home in Australia. So we really appreciate her being here, jet lagged and all. It's tomorrow lunchtime in Australia, so you might see sunlight coming in the window. Simone is not just any corporate representative, though. She's co-founder with her brother and ongoing board member of Neuroendocrine Cancer Australia and past president of the International Neuroendocrine Cancer Alliance. She has been working for many years tirelessly at many levels in Australia as what her organization calls a champion of early diagnosis and cure for neuroendocrine cancer, something which many of us have a lot of anxiety about. We're scared of it. We don't have good treatment for it. We don't have great diagnostics for it, but there are some very exciting things in the future, and Simone has been working to make sure that that all happens. She's been awarded a membership in the Order of Australia for service to humanity, and her experience is not only professional but personal as well, because unfortunately she lost a sister to a neuroendocrine pancreatic cancer. Ken has a great deal of respect for her. She's doing a lot of the same kind of work that we're doing. Very important, and maybe someday she'll give us a lecture herself, which she's quite capable of doing. Welcome, Simone.
Thank you so much, Dr. John, for that kind introduction. I hope you can hear me and see me, and I am looking also to try and share my screen, which I will endeavour to do. I'm wondering if you can see my screen?
Yes, we can.
Fantastic. Thank you so much. We love when technology works. And thank you again to ANCAN for the incredible opportunity to talk at your webinar very briefly about who we are at Telix, and yeah, to share just very briefly also my personal experience with this treatment and you know, this really important innovative technology. So Dr. John, as he mentioned, we are a commercial biotech company with a global footprint headquartered in Australia, but very much with the premise around Theranostics, so very much around targeted radionuclide therapy, as well as those radiopharmaceutical diagnostics. So we have, as Dr. John mentioned, Illuccix, which is various indications, including for imaging in men with prostate cancer with suspected metastases, who are candidates for initial definitive therapy, or with suspected reoccurrence based on elevated PSA levels, and also for selection of patients with metastatic disease for whom lutetium-177, which we're going to hear about from our expert speakers, is eligible for. But we also have regulatory filings underway in two other products in renal cancer and glioblastoma, which are very, very state-of-the-art and first to patients as well. We are really pushing for our Theranostics pipeline. Therapies are key to what we do. We want to see it, but we also want to treat it. So we have over 20 active clinical trials at the moment across these 8 indications. And I had the pleasure of talking with Rick at the recent ASCO GU meeting and other leading prostate cancer advocates around one of our Prostate Global studies, which I'll touch on in 1 second as well. But most importantly, with all these things that we're developing, we also really need to invest in our advanced supply chain and manufacturing. We need to ensure that we're creating these radioisotopes to the best and highest levels, but that we can also ensure that we can have the most robust supply chain so that we can get them to our patients as well. So very quickly, just with regards to our pipeline for prostate cancer, it is a very exciting one. It is hopefully reaching that unmet need. We have our imaging, but then we're actually really pushing forward with our phase 3 clinical trial in our antibody lutetium treatment called TLX591. And we can save that for another day and hope that we can actually talk to you about our Prostate Global study, and hopefully that you hear about it and are able to spread that to your communities as well. But I also wanted to touch on the fact that we have a Noble registry which looks at another isotope called technetium, which is really used for imaging in countries or areas which don't have access to PET but do have SPECT cameras. So again, looking at where we can ensure that we have a quality of access to these innovative technologies. We also are looking at the new isotopes such as actinium in one of our alpha therapy trials. And another exciting area is radio-guided surgery. So looking at surgical radiation detection and through probes that are compatible with Illuccix, so surgeons can actually look to see for disease in real time in the surgery. So what does this all mean in real life? Well, this is actually a photo of my beautiful sister, Kate. It was taken in 2008 at her wedding day. She, as Dr. John mentioned, unfortunately succumbed to very aggressive disease in prostate, sorry, not prostate, definitely not prostate, pancreatic neuroendocrine cancer. But a year prior to this photo, she was receiving lutetium treatment. And this treatment gave her this day. This treatment gave her low toxicity, but also higher quality of life. And whilst we are grateful that whilst, you know, we did eventually lose our sister, we were grateful for the life experiences that we were able to experience, as you can see here. So from this, and I know that you'll get this from the speakers as well, you know, we really need to work together to get more trials up and running and more data and access to these new and innovative technologies and for our prostate cancer community. And we also really need a multidisciplinary approach. So we really need all doctors to be upskilled in this area to make the best decisions and the best patient decisions as well, so that we can continue to have these beautiful life experiences and above all give hope to our communities. So thank you, Rick and Dr. John and ANCAN, for the incredible work you do and for the opportunity today. And thank you to the other industry partners for making this possible. And I so look forward to hearing from our esteemed speakers, Dr. Sartor and Dr. Keogh.
Thanks so much, Simone, and I hope we can talk to you again sometime in the future. It's a pleasure to host you on ANCAN.
Thank you. Thank you so much.
I'm going to introduce our first speaker now, Dr. Phillip Quell. He's a physician and also has a PhD in molecular physiology and biophysics. The doctor completed his residency in radiology and fellowship in nuclear medicine at Yale, which is near where I live in Connecticut. And I think he's the only doctor that I know that has quadruple board certifications: radiology, nuclear medicine, internal medicine, and nuclear cardiology. I can tell you just having one or two is very difficult, so that's a wonderful accomplishment. He's extensively published in nuclear medicine and has a particular expertise in prostate cancer, which is why he's here. Just in case you think that all that hard work would kill a man's sense of humor, he published an article one time that he called the washing machine hypothesis in an otherwise perfectly respectable medical journal. Besides his basic, translational, and clinical research, Dr. Quell has extensive clinical experience as well in a whole variety of imaging and interventional radiology, and he does a lot of teaching besides. He's serving now as Professor of Medical Imaging, Medicine, and Biomedical Engineering at the University of Arizona, having previously been Chief of Nuclear Medicine there. He does the work of several doctors, and we greatly appreciate him spending time with us. Welcome, Dr. Quell.
Hello, thank you for that very kind introduction. And thank you to ANCAN for the kind invitation to hopefully do some broaden the understanding of our rather complex field, as some of you alluded to. I've been actually, sorry, give me 1 second. Is this how am I doing on the AV side here?
It's good.
Okay, all right. So I've been given the topic and task of discussing the theory of how radionuclide diagnostics and theranostics works. And obviously this is a very complex area, but hopefully I can make the fundamentals understandable and give you some insights into this very important therapy and imaging that we do now for prostate cancer. So, you know, first a little elucidation on this topic of theranostics, which is a amalgamation of therapy and diagnostics into one term. And the term is actually not new. It started in 1998 was when it was first documented, but it has evolved, and I actually picked one particular definition, of which there are many in the literature, and I'll propose that for our platform for today, which is the Theranostics system integrates some form of diagnostic testing to determine the presence of a molecular target for which a specific drug is intended. This is from a nice review article by one of my old colleagues, Jean-Marc Day, which puts this in a bigger picture first. So we're going to do the classic keyhole. So let's start broad and personalized or precision medicine. What we do in nuclear medicine theranostics is a part of that. And so personalized medicine, particularly when it comes to cancer, is end to end. It starts with screening, then it goes to diagnosis, treatment, and follow-up. And we get these biomarkers from a variety of sources. There's fluids like blood, urine, biopsies, or imaging. And of course, we'll be talking most about imaging. And that gives us genomic information, pathologic information, and imaging, which is very real time. And then using imaging-based guidance, we can do interventional procedures, radioactive therapies like we'll be talking about as well here, and drug delivery and cell therapy. Let's go back in a little history lesson. Again, Theranostics is actually not new, and what's old is new again, right? So the first radioactive therapy was actually radioactive iodine and was first performed in 1941 by Saul Hertz. And he actually gave it not for cancer at the time, but for hyperthyroidism to treat overactive thyroid gland, because he made the brilliant deduction that this radioactive iodine will go just like regular iodine to your thyroid gland, the only gland in your body that really uses iodine, and could be used to treat diseases of the thyroid gland. Interestingly, this was used as a treatment first, and then the diagnostic testing came later. And then they developed the equipment to actually measure the uptake to really make this theranostic where you had the diagnostic test and the therapy performed together. While this was done at firstly for goiter or overactive thyroid gland, he knew that it could be used for the treatment of thyroid cancer. And so this really was the first success in cancer for radioactive theranostics, was this radioactive iodine, when they had this great success with it in a patient who was dying from thyroid cancer. But let's take a step back and look at what is this and how is this working on the molecular level. So what you're taking advantage of is that thyroid cancer, some of the times, and in fact most of the time, still remembers its cell of origin of thyroid tissue. And thyroid tissue is the only tissue in your body that selectively accumulates iodine. So in this particular tissue of thyroid origin, we have the ability to get this natural targeting with iodine. And we have radioactive iodine, iodine 131, which is damaging to normal tissues, but also can be damaging to cancers because it selectively can accumulate in these cancers. And so this is what we do on our daily basis in nuclear medicine, is where we combine our imaging with its ability to target certain molecules on tumors and do basically what the pathologists do. So we have a radioactive stain that we can image. And so in this pathology slide, going from A, B, C to D, you have increasing amounts of the target expression here. And to put in layman's terms, the more brown you see, the more there is expression on this thyroid cancer of the what's called a sodium iodide symporter, which is the target for the radioactive iodine. The more of this symporter that's expressed on the cells, the more iodine will get pumped inside to the cell, and then the radioactive iodine can kill that tumor cell. So where does the imaging come out? Well, radioactive iodine actually is very handy because it can provide images as well as treat the tumor. So this is a patient who we gave a sample dose of radioactive iodine for the imaging first, and you can see here is at the top of the head where the yellow arrow is, and then at the bottom of the image is about to the level of the hips, okay? And unfortunately, this patient had brain metastases, as you can see by the MRI on the side there. Also, there are lung metastases, and these are huge bone metastases. But the silver lining was that from this image, you can tell that these tumors still accumulate iodine. and they will accumulate radioactive iodine just as well as they will non-radioactive iodine. So we were able to successfully treat this patient. We couldn't cure this patient, but was able to give this patient a longer lifespan with a better quality of life through this therapy. So what makes a good radiotherapeutic agent, as well as often a good imaging agent, is this exemplified by the paradigm of radioactive iodine. So basically what we're trying to do for all sorts of cancers, in addition to, is the paradigm what we can do for thyroid cancer for radioactive iodine. Basically, first you have to start at getting high affinity of your drug, your radioactive molecule, to your target molecule that's expressed on the cancer. So that target molecule can be a receptor, a transport antigen, some type of target on your tumor. You need a drug that sticks to it with really high affinity. Then, once that drug binds to that target on the tumor surface, it needs to stay in there and hopefully internalized for a long period of time. This radioactive iodine image that you see here was actually taken days after the patient swallowed the radioactive iodine pill. So the drug needs to stay in the tumor for long periods of time in order to deliver enough radiation in order to kill that tumor. So, but last but not least, it's very important, you want this radiation to deliver a lot of dose to the tumor and very little to the rest of the body. And again, radioactive iodine does a good job of this. All these dark spots here are tumor. As you can see, you barely actually even know where the rest of the body is because there's so little radioactive iodine in the whole rest of the body. So that's the ideal. Whole lot of radioactive dose to the tumor with very little to the normal tissues of the body. So a quick primer on radioactive isotopes. Basically, all radioactive isotopes are isotopes that have too much energy or mass or both in their nucleus. So they want to give off that extra energy and mass. So if you have too much extra energy, you can give off that excess in the form of photons or light, which we can use for imaging to take pictures. If they have too much mass, they can give these off in the form of particles. Beta particles are just electrons, you know, like the electricity in your wall socket, or alpha particles, where actually are like helium atoms. Those are more massive. These particles will deliver energy to the inside of the cell and can destroy proteins and hopefully even destroy the DNA, damage the DNA of tumors, and that's why they are effective for therapies. And some molecules, isotopes like radioactive iodine, can give off both photons as well as particles, and therefore you can do both imaging and therapy. So while radioiodine is the exception because you have this natural targeting of iodine to thyroid cancer and thyroid tissue, for the vast majority of tumors, we have to have designer molecules, okay? So you find your target of choice on your tumor that's hopefully expressed at a very high level. You design a molecule that will bind to that target and then link that molecule to the radioactive isotope. If you wanted to, for imaging, you'll pick an isotope that emits light, so you can take pictures. If you want to kill tumor, you want to pick these radioactive isotopes that give off particles, either beta particles or alpha particles, to do the therapy. So let's explain this further with this analogy of the lock and key, where the lock is the target and the key is your drug, okay? So you have this target, and these molecules will have specific conformations and they'll have a specific configuration, so it's like a keyhole, and you need to develop a key or drug that fits onto that target very tightly, all right? And then you can bind that molecule, your drug, to make it radioactive and deliver radioactivity to the tumor. Let's change gears now to keyhole down to prostate cancer, and specifically to the revolution that has occurred with prostate specific membrane antigen, which I will call PSMA, targeted imaging and therapy. So many of you may have had a PET scan already, perhaps. It looks like basically a big CT scanner with the cover on, but this is what it looks like on the inside. You have a PET scanner on the front and a CT scanner on the back. You basically smush them together like a Reese's peanut butter cup, and you put a big housing on it so you can't tell what's on the inside. But basically it's two scanners in one. You have a PET scanner, which detects the radioactivity, that you use for imaging. So you get a PET image that is basically an image of where the radioactive drug is in your body. And then the CT scanner, which gives us our anatomical imaging. Again, like we did for thyroid cancer and radioactive iodine, let's go back to the basics, which is you fundamentally have to prove that your PSMA PET scan, when you give a radioactive drug that goes to the PSMA on the tumors, is really tracking how much there is PSMA on the tumor. And we being the field, did very important fundamental work showing that on histology, when you take out the tumor, the PSMA expression correlates very well with the amount of radioactivity on the PSMA PET scan. So here you have what we call an SUV max of 30, which is very high. And on the biopsy specimen, there's a lot of PSMA expressed on the prostate cancer tumor. And in this prostate cancer tumor, the uptake was very low. SUV max was an order of magnitude 10 times lower than the other one. As you can see, the PSMA expression on this tumor was very faint. So there's very good correlation between histology and PSMA expression shown on pathology and the amount of uptake we see in our PSMA PET scans. So prostate cancer is a spectrum, right? From when you first initially stage it as localized disease, but then it may recur, and then it could still be hormone sensitive, then it become castrate resistant, and then it can be refractory to many lines of cancer. PSMA expression tends, it's a very general statement, but tends to increase with prostate cancer aggressiveness, but then it will decline when you get to really aggressive neuroendocrine dedifferentiated or transdifferentiated cancer. So it's very important to know where you are here with PSMA PET scans, because there will be different levels of expression depending on where you are in the disease. And even within a singular category of disease, expression can still be kind of different, even though there is this general trend of higher PSMA expression with more aggressive tumors. But PSMA PET scans, this imaging of PSMA expression, is utilized now throughout prostate cancer. Diagnosis for where to biopsy and when to biopsy is still really in the research phases, but there are some good trials that show that there may be promise here. It has really changed and improved our accuracy of initial staging of disease to know if it's spread metastatic or not. It's helped our sensitivity for detection of recurrence of disease, selecting now patients for radioligand therapy and for monitoring response to therapies. Again, what's old is new. You know, PSMA was first heard about in last millennium in 1996. The first PSMA targeted agent was actually approved. There was actually an antibody called Prostasint that was labeled with a SPECT agent indium-111. And these were the images we got. You know, they worked, but they were very difficult to read, to be honest, and they weren't very sensitive a lot of times. But it really started the field off, okay? And unfortunately, you know, this was not widely used and kind of died off a little bit, but it really helped to jumpstart the field to know about PSMA targeting. And now we have 5 FDA-approved PSMA targeted radiopharmaceuticals, 4 diagnostic, 1 is therapeutic. Indium-111 Capromab was the original Prostasint that is really not used anymore. The next approved is gallium PSMA-11, which actually has 3 different approvals. Illuccix with Telix has a kit, and also Locomets with Novartis has a kit. The next to be approved is F-18 piflufolastat, which is trade name Pylarify. Next was F-18 fluorophilostat, which is Posluma. And of course, lutetium-177 PSMA-617 is Pluvicto, and this is the therapeutic agent. So we actually have a lot of keys. We have a lot of ways to target this PSMA molecule, and these are unapproved drugs that I have been involved with or is involved with actively right now. So as you can see, there's a whole slew of PSMA targeted radiopharmaceuticals that are in trials right now. Dr. Louise Emmett, who's an eminent nuclear medicine physician in Australia, did the primary trial, which looked at the value of PSMA PET for the evaluation of prostate cancer, initial diagnosis. And she found that adding PSMA PET to MRI, which is the standard of care, and prostate MRI, increases the sensitivity and negative predictive value for identifying clinically significant prostate cancer, but it did decrease the specificity a little bit. So I boxed the most important things here. sensitivity of the scan, which is how often you detect the prostate cancer. MRI was 83%, PSMA PET was 90%, but really the great number you want to see is when you combine the two, it was 97% sensitivity, so rarely misses one. But the specificity did go down from the low 50s to 40%. So a little bit of a penalty you pay in specificity by increasing the sensitivity. But in this early phase trial, it showed that there's great promise here. Here's an image from Dr. Emmett's paper, where there's this focus of uptake in the left prostate gland on PSMA PET, and the MRI was read as no clinically significant prostate cancer. And so the PET really added to the diagnostic accuracy of this patient. And so there's models coming out of combining MRI for PSMA PET for the diagnosis of primary prostate cancer, including when not to biopsy and where to biopsy, in addition to the more standardly accepted utilization of PSMA PET for initial staging for if it has spread to nodes or even distant beyond lymph nodes into the nodes in the abdomen or to other organs. This is a great study out of Australia again. Dr. Michael Hoffman, who's another one of the eminent experts in this field. And in this pro-PSMA study, they did a very important thing, which was they compared gallium PSMA-11 PET versus conventional imaging, which at that time was CT and bone scan. And the red squares here show you that you have higher accuracy and particularly sensitivity compared to CT and bone scan, because all the values are to the right here for PSMA PET, and the red boxes compared to CT and bone scan on the left. And you really don't sacrifice specificity. So it's a win-win. You get higher sensitivity with the same amount of high specificity when you use a PSMA PET scan instead of conventional imaging with CT and bone scan. And here's another example from that paper where the PSMA PET shows this clear focus of uptake in the iliac bone here. And when you go to the CT, you don't see a thing. You can show this to 100 radiologists. No one's going to call a bone metastasis there. And 6 months later, the bone metastasis was evident. So clearly you want to pick that up as early as possible because it could change the entire management of this patient. Pylarify, which is a commonly used PSMA PET agent. I just want to show the label here because it's the common for all the PSMA PET agents, which is for initial staging as well as biochemical recurrence. And this table shows a very oftenly asked question, which is at what PSA level is it accurate or a good idea when you have recurrence of prostate cancer to get a PSMA PET scan? And as you can see here, at 0.5 to 1 PSA, this had a 50% positivity rate. But even when you go below 0.5, as you can see, the percent positivity rate was still 35. So there's no absolute lower limit. This is the latest PSMA PET agent to be approved, Posluma. And again, you can see even at PSA levels less than 0.5, the percent PET positivity is 64%. So there's no lower limit, but you have to manage your expectations. I mean, if your PSA levels are really, really low, don't be shocked if your PSMA PET doesn't find anything. And you do have to run the risk at very low PSA levels that your false positive rates might actually go up. This is an example from a PSMA 11 scan, which shows this tiny, tiny lymph node, which you would never call under any circumstances in CT, but you can clearly see it has focal uptake. And at that point, you can discuss with your oncologist and determine what is the appropriate management at this point. It might be, for example, external beam therapy to just take care of that one site of recurrence and then monitor very closely, perhaps with just PSA to make sure it goes down and goes to 0, or perhaps with follow-up PSMA PET scans. Now, I've been showing you, of course, some home run PSMA PET images, but it's not always that easy. I'm not going to read these out to you, but just to show you that there's plenty of non-prostate cancers type of benign lesions that show PSMA uptake, and there's even cancers that are not prostate that show uptake. So not all that is PSMA PET positive is cancer or even specific necessarily for prostate cancer. So you do have to be careful and have a lot of experience when you're interpreting these PSMA PET images. Now for Theranostics, instead of using PSMA for diagnostic purposes, we can use PSMA PET to select the right patients for radioligand therapy targeting PSMA. So in this case, PSMA PET is not trying to say, is this particular lesion prostate cancer or not? You are trying to determine if a patient has tumors that have enough PSMA expression that when you treat it with a PSMA targeted agent, radioactive in this case, you're going to deliver enough radiation to kill that tumor. Okay, so the level of expression is here is just as important as finding lesions. So once your PSMA targeted agent binds the PSMA on the cell surface, it then gets brought inside the cancer cell by endocytosis, where then hopefully it can get close to the nucleus and damage the DNA and kill the tumor cell. So to extend that analogy of the lock and key and the target and drug, that key is the PSMA targeted drug. It gets into the target protein, PSMA, and then it opens up the cell, okay? And then you can deposit that drug in there. In this case, it's a radioactive drug and damages the DNA. The VISION trial, which gained FDA approval for our lutetium PSMA 617 or Pluvicto therapy, the only radioactive therapy approved by the FDA currently, actually used PSMA 11 PET for the diagnostic agent and for patient selection, and PSMA 617, this is actually the Pluvicto molecule. And as you can see, it's a good pair, diagnostic and therapeutic pair, because this in light green is the same targeting moiety, the same key for the lock, okay? But then they differ after that. This, the PSMA 11 is a different chelating moiety for the gallium versus the lutetium would be bound here for the lutetium PSMA 617. There are theranostic paradigms that use the exact same molecule, but in VISION, we actually use a different PSMA PET molecule from the therapeutic molecule. So again, you have the key, which is the same for PSMA 617, PSMA 11. That's why it's a good diagnostic pair and therapy pair. And then you have the linker and then the radioactive molecule, which is different. Use the gallium-68, which emits light for the imaging, versus for the therapeutic, you'd use lutetium-177, which emits the beta-emitting particle for a treatment. This is the schema that's used to select patients in the VISION trial. This is probably where most sites should start for selecting patients, but then every patient is different. So you don't necessarily have to follow this to the T for treatment purposes. And this was, for example, of a patient who had some PSMA positive disease, but this liver metastasis was PSMA negative, meaning it didn't express enough PSMA that we thought it would respond to a therapy. So this was the type of patient that we did not treat in the VISION trial. The VISION trial had these great results in this treatment patient population that very few, basically almost no real great alternatives for more treatment. And I want to show what's more kind of cutting edge to end my talk. In this FDA required postdoc study that I designed, we did for the first time, we quantified these baseline PSMA PET scans before they got therapy to see if we could predict who was going to respond to the radioactive therapy. So we used a combination of artificial intelligence as well as manual segmentation to segment out all the PSMA positive disease, which is color coded here by organ system. And then we derived a bunch of parameters to determine the amount, to express the amount of activity that was in these, which is a surrogate for how much PSMA was expressed. And we did a whole bunch of modeling, and it actually turned out to be fairly simple. When you segment out all the PSMA positive disease and you just take the average of all the disease in the body, every single little, milliliter, that was actually the best predictor of outcome when you're treated with the lutetium PSMA 617. And in fact, for every 1 unit increase in the average SUV, or which is the quantitative measure of activity in the patient, you had a 10% decrease in the risk of death. And actually, if you do the analysis further, let's just look here on the right side for the purposes of time. There's a fairly linear correlation, although as you can see, there's a lot of error, there's significant deviation at each point. But when you look across the entire SUV mean here is 7, and we go up to 18 here. So as you increase the SUV, there's a fairly linear correlation where as you have higher expression of PSMA on the tumors, on average, you're going to respond better to Pluvicto, and you're going to have a decreased risk of death. So that's where we're going. You know, almost no place I know of standardly can calculate this whole body SUV mean. This was done in a research setting, but these tools are becoming more and more readily available by software that's commercially available. And I think a lot of us foresee that this will get put into clinical use very soon, probably in 2024 at various sites. So in summary, PSMA PET has transformed prostate cancer care by improving the entire spectrum of prostate cancer care, from staging, evaluation, recurrence, selecting patients for targeted therapy, monitoring response. And Theranostics is now part of the everyday practice. And nuclear medicine is uniquely suited to play a central role in the present and future of PSMA targeted diagnosis and therapy, because we can do imaging as well as therapy. And thank you to your patients and caregivers. Hopefully I've made this very complex field a little bit more clear.
Nice, thank you very, very much. I was especially happy to see your work on SUV mean. I think that's going to really help a lot of us out, because there are times when we have members who are heading into PSMA PET scanning and considering Pluvicto. This is in the metastatic CRPT area. And we have lately found ourselves really tempted to push them into getting like 18F-FDG PET scans in order to compare with their PSMA PET scans. And instead of, well, I don't know, maybe you could tell us about that. It doesn't sound like it's really necessary for us to be doing that very long. Mm-hmm. Can you tell us whether we should ask our doctors for FDG scans, or whether they can figure it out from background of liver spleen SUV, or whether this method that you're talking about might come to be available soon?
Yeah, so the vision, the read rules that were performed in Vision for patient eligibility is what I think at first cut should be used as screening. And this, of course, this is my opinion, because that was used in the trial. And when we designed those Vision read rules, I don't think too many people know about this, but basically I designed and tested it to exclude 10 to 20% of the patients that would benefit the least from lutetium PSMA 617. Now, if you exclude more patients and are more selective about patients who have the highest levels, you'll get better responses. But this is a patient population, as you said, with metastatic castrate-resistant prostate cancer that already failed chemotherapy, that have almost no great treatment options left. So you don't want to exclude too many patients, because you're going to be potentially denying patients that may benefit, even if they're not benefiting the best, you know, from getting a therapy that's really their only option. If you divide by quartiles, the top quartile had an overall survival of, so the median was 4 months, but the top quartile had a median overall survival of 6 months, and the bottom had a median overall survival in the 3 range. So there was a doubling between the bottom quartile and the top quartile, but still, even in the bottom quartile, they benefited, right? And so that equation may change in the future when you have other therapies to offer. If you have another therapy that, for example, can get you 4 months, then yeah, we want to be more selective and make sure, hey, okay, this one, if you're in this group, you're going to get 6 months from this likely. So we want to start with this one at least. But right now, there's not too many treatment options. So if you use that visual interpretation is what we did in the Vision trial, no quantification required. You just follow that flow chart like I showed you, just kind of flashed by, sorry. That is, I think, a good initial cut. And that'll exclude somewhere between 10 and 20% of the patients that will sort of respond the worst. Now, there will be patients that don't make that cut, but you look at it and there's a very specific reason you still might want to treat them. That's totally fine, but I think it's a little a good starting place. That visual interpretation does not require FDG PET at all. There are many reasons that I pushed for that in the beginning. It's kind of beyond the scope of the discussion, but it doesn't need that. So my personal recommendation is to just start with what we did with the vision trial, which just requires a PSMA PET and a diagnostic CT. And then if you need a tiebreaker, there's a specific situation, FDG can be really helpful. So for example, you have a residual mass or node or bone metastasis that isn't PSMA positive, and you're wondering, is that because you treated it before, or is it because it's an active tumor that is just not expressing PSMA? That's a great example. Let's do an FDG PET scan and see if that tumor takes up FDG, it's active and it's just not expressing PSMA. If it's completely FDG negative, then it's probably just been well treated, and you wouldn't want to exclude that patient because they, for example, got external beam radiation there, and the radiation oncologist did a great job of treating that tumor. So that would be my recommendation. Start with just the PSMA PET with the diagnostic CT like we did in Vision as a first cut, but specific situations still certainly may require, FDG PET. As you saw, when we take it to the next step of using sort of stratifying how patients are going to respond, at least roughly, with quantification of the whole body tumor volume, that also doesn't require FDG PET, it's purely from your PSMA PET. So another good example of where FDG PET, a great prognostic tool, like it is for many diseases. But I think for the selection of PSMA targeted therapy, radioligand therapy, for the time being, I think it should not be considered absolutely mandatory. And I really wouldn't delay therapy trying to get insurance approval to get an FDG PET for it.
Thank you. Yeah, it comes up kind of a lot in our group discussion.
There we go. Okay. Yeah, so Theranostics, and actually this was nicely covered by Phil, and I'll simply say that you need to be able to have a cell surface receptor that was the lock into which you insert the key, according to this analogy, which is really good. And you put a radionuclide on there, and then you can diagnose or treat depending on which one you want to do. And you can even do both. You can diagnose and treat with certain nucleotides. Next slide. And one of the things that I think is a little bit interesting, we get very enamored with PSMA, and we should, but there are a large number of other potential targets that are being explored. STEAP1, HK2, PSCA, prostate stem cell antigen, GPC3, GRPR, which is the bombacin receptor, TROP2, DLL3. These are things that don't make much sense, but nevertheless, they're being explored in a variety of settings. And I'll simply say that PSMA is in the lead, but there are other things that are getting a serious consideration now. Next slide. This is PSMA. One of the things I liked that Phil did is he introduced the prostate, which was the original PSMA targeted antibody. Not a very good one, and nobody uses it anymore, but nevertheless, the molecule is a transmembrane protein, and you can target it with a variety of different ways. Next slide. One of the things nice about PSMA is it's hot in the prostate. It's also expressed in other tissues. PSMA stands for prostate-specific membrane antigen. It's not really specific. When Phil was showing the images, I think you could readily see the uptake in the salivary glands, a degree of uptake in both the liver and the spleen, the intestine, obviously excreted through the bladder, some uptake in the kidneys, passes through the kidneys. But nevertheless, it certainly is good enough. Next slide. Phil had talked about the different ways to kind of put a lock inside the key. And they're small molecules, peptides, antibodies, camelid antibodies, minibodies, and antibodies, aptamers. There's a lot of different ways to skin the cat. These are the different forms of the key that is going to fit into the lock. And, you know, they're clever chemists out there, and they're designing more and more ways. So that's a good thing. Next. The ones that we have the most clinical data are 4 molecules. I'm leaving one off here. PSMA-11 is an imaging agent used with gallium-68. The other common imager is Pylarify, also known as DCF-PYL. This PSMA-617, which is also known as Pluvicto, and PSMA-INT, which is also known as 0.2002, and it's also being explored in other studies with curium. Now, I put a little arrow there by the chelate, and one of the things that Phil had mentioned is you can put various isotopes, and those different isotopes can either image or treat. By the way, INT stands for image and treat, and you can put various molecules such as gallium or lutetium or even actinium in these slots, and you can serve different purposes with the same molecule. Next slide. We have focused a bit on lutetium-177, although I will say that Phil did mention I-131, which is sort of the grandfather when it comes to the treatment and theranostic approach, and that's not going to be typically used in prostate, but it's going to be used in the treatment of thyroid cancer with the Simporter that, again, Phil showed. The studies with beta emitters are most advanced with lutetium, but there's studies with copper, studies with terbium that are now ongoing that look interesting, and other ones that are used in humans, such as the radium strontium-89 for bone targeting. Cerium-153 can be one of chelates, FDA approved for bone targeting, P32 and yttrium. But lutetium is the one that most people are going to be focused on. Next slide. This is an example of terbium-161. It's an up-and-coming isotope. Might work pretty well in some small clusters. It has what we call an Auger electron, which is a very, very low energy. We need more work to do. I'm just sort of highlighting the fact that people are looking at other molecules, and people are being given terbium-161. I just spoke to a fellow out of Perth, Australia, who's using terbium-161 in people. It definitely works. Next slide. One of the things that the betas, and this is going to be true for lutetium and all the other betas, is that it requires a little bit of something we call crossfire. The actual deposition on the cell surface may not even kill the cell to which it is bound, but in a tumor mass, you're going to have the crossfire of the beta, and that radiation is going to help kill a tumor mass. Now, interestingly, betas are not particularly effective for single cells or very small cell clusters because a variety of the energy, a majority of the energy may be expended outside of the cell. So a little bit of a tumor mass is probably best for the beta. That's what almost all the experiments show. Next slide. This is the vision paper. Next slide. And Phil introduced it really, really well in terms of the image selection and comparison to liver and uptake, etc. Here you see the overall survival curves and the RPFS curves. Truthfully, I was a little disappointed. It didn't quite produce as much as I would have hoped, but nevertheless, there are clear activity relative to the standard of care. And remember, in the vision trial, it was standard of care plus lutetium. It wasn't just lutetium alone. Next slide. This is a really nice demonstration of the importance of PSA decline. And these are survival curves, and the higher you are, the better it is. If you look at that bottom curve, those are people who had no PSA decline, and the median survival was probably somewhere around 8 to 9 months, whereas the median was not reached if you had a good PSA decline, 90% or more. And then you can see the grades. Now, this is PSA decline in sometime during the first 12 weeks, but nevertheless, an important prognostic finding. Next slide. Here's the slide that Phil showed. This is taken from Phil. If you notice, I have the reference up there from his EA&M presentation in 2023. And Phil made this point earlier. There is a clear relationship between the time to progression and the overall survival and the degree of uptake that you see in the PSMA PET. One of the things, and Phil said this as well, it's hard to come up with a really distinct cut point. You can't say, you're not going to respond if your PSA or PSMA SUV mean is below X or below 0.5X. You can see it's really shades of gray. It's not an absolute cutoff, but the more uptake you have, and this is PSMA SUV mean, the better you do. By the way, if you look at SUV max, it's not that much different, but nevertheless, SUV mean was used in Phil's presentation at the EA&M. Next slide. EA&M is European Association of Nuclear Medicine. This is actually from the presentation that I gave at the European Association of Nuclear Medicine this past year. And we were looking at circulating tumor DNA and then trying to find markers that might predict resistance. And it's a relatively small sample set, but nevertheless, we did find CCNE1 amplification, FGFR1 amplification, CDK12 mutation as being statistically significant in a very small sample set. We're getting further verification on these and more as we go forward. So I regard this as exploratory, not definitive. Next slide. So what do we not know about vision? I think we still have a little bit of work to do for optimal patient selection. Phil covered that. The FDG PET occasionally may be useful, but using the read rules that were discussed earlier, I think you can get a lot of what you need out of PSMA PET. This issue about optimal dose and schedule for therapy, I don't think we really know the right dose. I'm not sure we know the right schedule. Again, quoting Louise Emmett, she's been a strong proponent for adaptive dosing, and I think that's important. What about retreatment and progression? Can that make a positive impact? We don't know definitively. There are some studies coming out of both Europe and Australia that would suggest yes, but good luck getting the insurance to pay for it. They're not going to. What about the standard of care that was used in vision? I think that likely the standard of care did make a difference, but we'd have to run really controlled trials. I will say in the vision trial that the standard of care plus lutetium seemed to look a little bit better. Pre-chemotherapy space, we'll talk about that in a second, because vision was done. Everybody had to have a novel hormone and a taxane, at least something like Abienza and a taxane. But now we have newer data in the pre-chemotherapy space, and then synergy. I'll briefly talk about some possibilities of synergy. Next slide. New important trials, PSMA-4, SPLASH. There's now a press release on SPLASH, and then there is a completed accrual, but no data from ECLIPSE. ESMO is European Society of Medical Oncology. Next slide. This was in last fall. I presented the data from PSMA-4, which is taxane naive. These are people, all of whom had a Abienza type drug, but had not been pretreated with a taxane. Essentially, there are a few who were, but the vast majority had not. Next slide. The read rules were similar to vision on the PSMA PET. There's a little bit difference in the design. It was not standard of care plus or minus lutetium. it was lutetium versus a change in hormones. It's a little bit different design. One of the important things, next slide, is that crossover was allowed. So we have a good readout on what we call RPFS. It's radiographic progression-free survival. This is how long it takes for your images to show evidence of progression. And when I say images here, I mean CAT scans and bone scans. I do not mean PSMA PET. That's led to some discussion. Hazard ratio of 0.43 means that the reduction was more than half. If you actually look at the median time, you see 12.02 months versus 5.59 months in the control group. Next slide. 84% of the patients who were eligible crossed over. There was no difference in overall survival. The follow-up is relatively short, only about 12.7 versus 13 months. There's an estimate on median overall survival, about 19 months in each arm. There is clear immaturity. 234 patients were treated with lutetium. 29.5% of those patients, the intent to treat, had died. That's 69 had died, and in the hormonal arm, it was 65 or 27.8. It's early data. I think that's important. Almost everybody wants to see more data, including me. Next slide. Synergistic opportunities, these are speculative. Next slide. Is data to suggest in animals that if you combine lutetium with an inhibitor of DNA repair, such as a PARP inhibitor, those are things like olaparib or rucaparib, that you might do better. Maybe an ATR inhibitor could be better as well, maybe a DNA PK inhibitor. If you damage the DNA and then inhibit the repair, that's probably good. Next slide. And there's some data, a little more speculative in my mind, that you might be able to radiate tumors, inform new responsiveness to immunotherapy. I say this is speculative. Next slide. Alpha particles are different than betas. Next slide. Alpha particles are big particles. Phil made an illusion, but they're over 7,000 times larger and very, very, very energetic. The betas are small. They're basically an electron. Alphas are 2 protons, 2 neutrons. They don't move as fast. Betas go almost the speed of light. Alphas go about 6% of the speed of light. But nevertheless, they don't go very far. And there's a lot of enthusiasm around the alphas right now. Next slide. There's more than one alpha. Actinium is one where you have most of the data, but leads are making a push. And astatine-211 is also making a push. You have to watch these different isotopes, different molecules, a lot of activity here. Next slide. This is an example of actinium-225 overcoming resistance to PSMA lutetium. Somebody gets treated with lutetium, they've got a rising PSA. They clearly have very prominent disease and no diminishing disease after lutetium, and yet they can still respond to the actinium-225. And so this is sort of the power of the alpha, and it's being explored in a variety of settings. Next slide. The current commercial alpha programs are ongoing at a whole series of different companies: Convergent, Fusion, Telix, Point Biopharma, Bayer, Novartis, ITM Janssen are all looking at actinium. Lead-212 is being looked at our Bio, Viewpoint, Advanced Cell. Viewpoint, by the way, is no longer Viewpoint, it's now Perspective. And astatine-211 is being looked at for Z-alpha. And, come back next week, and there might be another one, maybe a Ranamed. But, it's very, very rapidly changing field, a lot of enthusiasm, a lot of companies, and it's just now breaking into the humans. Next slide. So where do you go from here? I think, PSMA is great. We're going to have different targets. We already do have some different targets. We're going to have different isotopes in lutetium, and I've already mentioned a couple. There's studies being done in people with terbium. There's studies being done in people with lead, with actinium. There's going to be a whole series of different combinations. You can have alpha beta combos, immunotherapy combos, along with the isotopes, DNA repair inhibitors such as olaparib, chemotherapies, radiation sensitizers, moving in earlier stages, lots and lots and lots of stuff. And that's all I had to say. Hopefully I've covered it in a pretty short amount of time. And I see that Phil's still on the call, so we can kind of tag team here. And if anybody wants to ask a question, I can defer to Phil, or Phil can defer to me, depending on what the question might be.
Thanks so much. That was great. I don't suppose you want an introduction retrospectively, or should we forge on ahead?
Oh, just forge on ahead. You can Google me if you like.
The time is short. I'll only ask one question, and then I'm going to pass it on to we have 100 and something people in the audience that I bet have questions. You piqued my interest when you said maybe even FAP for your list of targets that were being looked at, and I wondered why you said that.
Well, I'm aware that at least one patient has been treated with prostate cancer, but I don't know what the outcome is. FAP is fibroblast activated protein. It's expressed in the stroma, not on the cell surface of most tumors. It is expressed on the cell surface of some mesenchymal sarcomas, but we're not here to talk about sarcomas tonight. It is a good imaging agent for a whole series, over 30 tumors. I'll simply say for ovarian, it might be better than FTG and the alternatives, but we need more data, and we need sticky FAPs. A lot of the FAPs are not very, FAP binders, or FAPs they're called, are not very good in binding. But I've seen at least 2 that I think are pretty good, and we'll have to, wait till we have more.
Go on to the next one.
Okay, are there future treatments that might even be more effective than lutetium? I think Dr. Sartor just answered that question, no?
Yeah, and remember, we're focused on isotopes here. There's some other things that look interesting. There's STEAP1 bispecific that looks pretty nice. There's some nice antigen receptor degraders that are kind of making their way through. There are new PARP inhibitors that may look better, and then there are combinations. So, I'm very prone to the isotopes. I spend a lot of time, but there are other promising therapies coming along as well.
Len has another one here. Supposing lutetium PSMA 617 is successful in killing some of or all of the cancer cells that are found, how long is it typically before additional sites of metastasis occur? And how many times can this type of treatment effectively be used for one patient before the accumulated treatment radiation can itself lead to additional cancers? Well, you already mentioned the insurance problems with repeat lutetium.
Yeah,
Can you address some of the other?
I can answer it really quickly, John. We're limited to 6 in the United States. I presented 2 data sets, one vision, which is in the post-taxane space. Median time to progression was 8.3 months. Median time to progression in the pre-taxane space was 12.02 months. So those are ballparks about how long it'll take before something new shows up.
Okay.
John, I've got a question.
Okay, Ben, thank you. This is Ben Nathanson, gentlemen.
So one concern I have in the diagnostic space is the proliferation of radio labels and linkers and chelators that they're going to be different to read. We already have comparisons, different peculiarities of F18 and CU and gallium-68. As the space gets bigger and bigger with more and more variations, there's going to be more and more peculiarities in each particular radioligand that's used. And it's going to become harder and harder to read, or it's going to be harder and harder to find somebody who can read all of these. Don't you think?
Yeah, maybe I'll take this, Oliver. Honestly, one of the main things about being a good radiologist is that we did all that medical school training, and even during radiology residency, we learned a lot about pathology. And that same, likewise in nuclear medicine residency, you really have to understand the pathology, and then all that training gives you the experience into understanding the pattern of disease, so that you don't miscall things. Just because it has uptake and it's positive doesn't mean it's disease. The mistake that people make is that they think everything that's lights up is cancer. So that's actually the far more common mistake, is just calling everything they see positive. I mean, sometimes I've opened up cases, not necessarily with PSMA, which is pretty specific tracer, but they see all these spots and everything's being called and nothing's disease. You're like, well, what's going on here? So the tracers are similar enough, at least the ones that are approved, and even the ones that are, coming out, they're similar enough that those basic tenets still hold. So I think actually that when something new comes out, you're absolutely right. There's going to be a learning curve, but it won't be that, it won't be that long. People will adapt fairly quickly. But you're right. We've already undergone that transition, for example, in the neuroendocrine tumor space, where we went with the somatostatin receptor imaging from SPECT to PET with gallium, and now we have copper. There's now copper PSMA PET agents coming out as well. And you're right, they do look a little different, but the essential patterns of disease that you're going to seeing that we're diagnosing for and evaluating for recurrence are about the same. So I actually don't think it'll be that challenging. If you do this on a regular basis, it'll be okay.
Thank you.
Yeah, I've got a number of questions here actually on the give and take between the clinic and the radionuclide lab. The give and take between the radiologist and the clinician. The communication between the two, when they disagree, when they agree, how does that get sorted out in order for the oncologist to decide what treatment to give?
It's really not much disagreement, first of all. The thing that I'll say is that an oncologist is aware of the multiplicity of other treatments, whether or not that be androgen receptor degraders, PARP inhibitors, immunotherapies, a little more versed in the genetics of the disease, looking at circulating tumor DNA, germline genetics, somatic genetics. For somebody who spends all day long in the clinic trying to manage prostate cancer patients, it's pretty hard to beat an oncologist for decision making. However, when it comes to looking at the subtleties in the scans, we talk a lot of patients over and try to determine suitability. And, Phil had mentioned things about false positives, false negatives, degree of uptake, SUV mean, distribution, etc., all of which are important. One of the things that was not mentioned, but I feel like I should mention it, if you just got 1 or 2 spots of disease, you probably don't need Pluvicto. We can just SBRT that. And that's a very powerful tool. I saw a patient recently who came in for Pluvicto. He had 2 spots. I said, SBRT that, come back when you got a problem. Another thing that we have to worry about are liver lesions. Liver lesions do not do well. And even when there's pretty good uptake, the response is short. And we may consider alternative treatments for liver lesions. I've even done liver resections or Y90, yttrium-90 treatments. So the treatment decisions that need to be made are broad and big. We absolutely discuss things as a group, but it's hard to be a medical oncologist if you want to find out what the alternatives are. That's a personal opinion. I don't know, Phil, if you would agree.
Well,
Do you want to weigh in on that, Dr. Cole?
The same institution, but again, there's not that much disagreement really, between
really
colleagues. There's really not, and patients, particularly at when a patient started therapy, a lot of the decision whether to keep someone on the drug is going to be the side effect profile, really, right? So again, the medical oncologist, will probably be seeing the patient more often than the nuclear medicine physician. Certainly they could see us more frequently if they need to, but then they're just going to appointments all the time. So the discussions, I think, won't really result in too much indecision at this point. But as Oliver said, we're sort of at the beginning of all this, really. As treatments get more complex, the discussions are going to get more complex about, and we're going to be doing PSMA PET or lutetium SPECT imaging to monitor response, more and more often. It's becoming more standard in the field, and that's going to add another complex bit of data that's going to require not more, more discussion between each other, and yeah, it'll be very exciting. The combination of therapies is just going to get more complicated. Every time we add something new, the image interpretation becomes more complicated. As
Yeah.
Oliver knows, nuclear medicine is a two-edged sword. It's great, but it's also, as soon you can find out one critical piece of history, and then it changes your interpretation completely off the exact same image. And a lot of this can sometimes only come out in the multidisciplinary tumor boards, right?
Well, Phil, that's exactly what I was about to point out. There are two specialists here. We got a medical oncologist, we have nuclear medicine. And honestly, we don't disagree very often. But remember, we have other specialists who might be involved. In some cases, radiation oncologists need to be part of the discussion. Think, what about cord compression? What about SBRT? Ultimately, those are radiation oncology decisions. And intermittently, we may need urology for things like urethral obstruction, urethral obstruction, issues that need to be handled from the perspective of the urinary tract. And so it's not just two specialties, it's more than two.
And
So
Oliver, you're
I'd like
bringing
to.
out the liver metastatic patients. That's a subgroup that the hazard ratio was still, error bar still went above 1. And that's a group that, like as you pointed out, really, really needs multidisciplinary care. It could be SBRT to liver, it could be Y90 radioembolization. And sort of the same, it kind of applies to lung nodules. There's great disparity in the aggressiveness of pulmonary metastases in prostate cancer. You might want to radiofrequency ablate something, rather than give them Pluvicto in a certain situation.
I'd like to come back. I'd like to come back and ask Dr. Sartor a question that was posed to Dr. Kuo earlier on, which was about this concordance issue. And I got Dr. Kuo's response, which is maybe necessary, but probably not, because we're going to do everything we can with the radionuclide to treat what is there. I wonder if Dr. Sartor sees it the same way. Before determining whether he's going to prescribe a radionuclide, PSMA sensitized protocol, is he going to be concerned with how much of the patient's cancer exhibits the PSMA?
Of course, Rick. That's part of the decision making. We don't have an automatic Pluvicto switch. I personally look at every single scan before treating, and often discuss it with one of my nuclear medicine colleagues. I'm not only looking for the ones that are PSMA PET positive, I'm looking for the ones that are not. I'm looking at the liver carefully. I'm looking at lytic bone lesions. I'm looking for masses that may not be defined by their PSMA PET uptake. But I don't think Phil and I have any disagreement on that. Or if we did, I'd be very surprised.
No disagreement. But, also, as just to reemphasize what Oliver was mentioning, it's, if you're doing whole body SUV mean, there's certainly not, if someone has an SUV mean of 9, I'm not going to treat them if only treat people if they had a 10 instead. It's far more nuanced than that. And the PSMA PET vision read rule criteria, even the patients that met that bar, even the ones with the lowest whole body SUV mean, still got some benefit. And I thought, Rick, were you talking about the FDG question at all, or was that not what you meant.
Yeah,
Or
I was talking about the FDG question, and the reason it comes up is because what we see in our groups more and more often are the gents who may start off doing fairly well on a radionuclide, and after the second or third session, nothing more happens, and the PSA may start to rise a little bit. We don't see any change, a huge amount of change in the PSMA PET scans down the road. And then it turns out these are the guys who have already got this neoplastic morphing disease, and were never going to respond in the first place.
No. Rick, let me give what I believe will be
Please.
a helpful comment. I presented the PSA decline curves within the first 12 weeks. Let's divide those into 3 categories because that's going to be reasonably accurate. Number 1 is you have about a third of the patients who don't respond worth a damn, and you know it within 12 weeks. You've got another third of the patients who are like, oh my goodness gracious, can you believe what just happened? Recently saw a patient whose PSA went from 750 down to 2 in the course of 12 weeks. And then, of course, you have the folks in between. And these rule of thirds. So what we are enthusiastic about our new therapies, but rarely do we stop and talk about the third of patients who are not responding. And we need better therapies for those patients. And we don't persist in flagellating the dead cow if in fact the disease is not responding. We move on. Why give a therapy to which a patient is not responding? Doesn't make sense to me. Now you might have the possibility of a mixed response. Some lesions getting better, some worse. In which case, maybe you want to do some SBRT or something like that. But we don't flagellate the patients who are not responding. And for those patients that are responding, we want to keep at it. But most of the time, we don't have much, at least in our shop, we don't have a lot of discrepancy between treating and non-treating. And if we have a clear signal to stop, we stop and move on.
Thank you. Thank you very much, Dr. Sartor, for clarifying that.
I got an imaging question. A number of us over the recent years have been taking drug holidays, and our oncologists like to monitor us with PSA. We've been aware from a little bit of our own experience and from Prevail and Arches that you can have recurrence on imaging without any movement in the PSA. So do you think that that we should monitor people on drug holidays with both?
You know, I'll venture to say that if our Louise Emmett, who's already been mentioned at least once tonight, that she would strongly advocate so-called adaptive dosing to be able to stop when the responses are good and then retreat a little later. You know, it turns out that in the Vision trial, we just had every 6 weeks as the plan. I believe in the future we'll be a little more better about adaptive dosing, and maybe we even have dose escalations or de-escalations, pauses, intermittent therapies. But right now we're kind of feeling our way forward with a little bit of uncertainty because the trials are not complete. I don't know, Phil, if you would agree or disagree with that.
I totally agree. There's a lot of uncertainty there. And then the practical application of insurance coverage makes it a little bit extra challenging, to be perfectly honest, in real life. So between those two, I think it's really not a cop-out. It's the right, it's individual based. It really depends on, you have to take it on a case-by-case basis.
And John, you know, one of the things I would like for patients to be respectful of is the fact that we don't know all the answers. You know, how do we know what we know without good comparative trials? And I get a lot of great questions, but I don't always have a lot of great answers because we just don't have the data.
Lynn and Ben, have you been aware of any more audience questions?
Well, I've got one of my own, John, which is picking up on Rick's question about checking for concordance with something like an FDG scan, would any metabolic scan be useful in checking for concordance, like Axumin or choline or whatever?
I want to hear what Phil says. We've used here at Mayo some of the choline scans. I think we can use that for discrepancy. I have personally preferred, remember, we're getting cross-sectional imaging with a CAT scan, typically with contrast, in order to evaluate those lesions in more detail. And an FDG, I rarely, if ever, I'm trying to remember the last time I went to something other than CAT scan, MRI, and FDG PET. I can't remember anything. I don't know, Phil, what your thoughts?
Agree. I have no personal experience with C11 choline, but FDG is a very powerful tool. As I mentioned earlier, I don't think it's mandatory that you use it in your selection process for Pluvicto, but it's a great troubleshooting tool, and it is remain.
You already mentioned Pluvicto in the MHSPC space. This isn't something we can do clinically yet, is it? No, this is just trials.
Yeah, just trials. We did a big trial called the PSMA addition trial, over 1,100 patients. It's fully accrued, but it's not available in routine practice.
How long do you think it'll be before we see an alpha in the clinic? Years still?
It's there now. I was on a call today with PSMA INT actinium-225 with Fusion's molecule, and then on Wednesday I was on with J591 actinium-225, which is predominantly being done at Cornell, but I was giving it down at Tulane as well.
No.
So their trials ongoing in the U.S. right here, right now, not tomorrow, right here, right now.
And you did show us a slide of somebody who failed Pluvicto and responded to actinium, didn't you?
I did. That was a German slide, but I'll just say that Fusion with PSMA INT actinium-225 and Convergent, which is coming out of Cornell, both have actinium trials.
And I would just mention that the neuroendocrine space is also, again, following in parallel, if not a little bit ahead, with actinium targeted somatostatin receptor Theranostics. And again, just for the audience that's not into nuclear physics too much. So a beta particle, as Oliver said, is an electron. So it's a particle coming out very high energy and can travel farther distances than alphas, but its impact radius is tiny. It's kind of like the difference between like a BB gun and like a shotgun blast. When you got an alpha, it's a much larger cross-sectional area. And so even though they are both within the larger category of particulate radiation, their mechanism of tumor cytotoxicity is different. So you really have to think about it differently. Just like you cannot say, we're giving you chemotherapy. Not all chemotherapy is the same. There's different kinds of chemotherapy that have different mechanisms of action. Beta particles and alpha particle therapeutic radiation, they're therapeutic particulate radiation, but they have different mechanisms of cytotoxicity. So we should expect them to potentially have efficacy with alphas after betas because they do have a different mechanism of cell kill.
That's encouraging.
Before we lose the docs, there's a lot of people asking about how early could we use Pluvicto, and where are we going in the future with radionuclide protocols much earlier in the disease cycle. We'd love to hear what both of you have to say about that.
Well, it's pretty clear. We have designed with Novartis a trial called the PSMA DC trial that is going to take PSMA PET positive patients who have no conventional imaging lesions seen on their bone scan CAT scan, treat them with SBRT 1 to 5 lesions, and then randomized to Pluvicto. That trial is called the PSMA DC trial. It'll be open this year. So that is hormone sensitive, castrate none, no castrate, and SPRT plus or minus lutetium. That's pretty damn early. That trial's ongoing this year.
Wow.
And just
Wow.
it's even at the earliest state. I mean, this trial will, yeah, obviously there needs to be a bigger trial, but Oliver, it's called the lutectomy trial, right? The one in the neoadjuvant?
Lutectomy was done in Australia. It opened and closed. It was an Australian trial, and it used neoadjuvant prior to surgery, but it was not really designed as a therapeutic trial per se, but more as a let's see what we can find.
Yeah, proof of principle.
I don't think any patient had a complete remission. There were some patients who responded and the PSAs went down, but nobody had a complete remission on that one.
Yeah, but they at surgery, which they did have, a lot of the nodes showed significant necrosis, if I'm not mistaken.
Yes, there was evidence of cell kill. Yeah. They just didn't get to complete remission on it. But the doses were pretty small, and the number of doses was small. So it was not a dose optimized study at all. But it's not available I don't know if anybody, I don't know, Phil, do you know anybody doing neoadjuvant in the US? There's been talk about it, but the only data is out of Australia, maybe somebody in Germany, but I haven't seen it published.
Yeah, but at least that's an example of someone, the Australian group, again, pushing it really to the forefront at the initial therapy, very early days. And anything that early would take for a very long readout time, of course.
Let me expand on Phil's point right now. If you want to get an FDA approval today, the endpoints that are accepted include metastasis-free survival on conventional imaging, or radiographic progression-free survival on conventional imaging, or overall survival. Now, the typical follow-up for an advanced prostate cancer patient trial, of which I've been a part of, is going to be somewhere between 7 and 10 years, and the number of patients is going to be 600 or more. Now, let's do some cost on that. That's a $300, $400, $500 million trial. You put up the money, I'll do the study. But most people don't want to put up the money because it takes so damn long to get a readout, and the technology changes yet again. So the reason people do trials where you can get a readout is not just because it's interesting, it's also because of the economics.
I like that. Ben, you're shaking your head a lot there. What are your thoughts? Oh, you're muted. We can't hear you, but that's okay.
I'm nodding because it makes sense.
Yeah. Unfortunately. No, but it's part of the art form is to design trials within a budget that is affordable. And you talk to the small pharma people, and their whole market cap may be 300 million.
Yeah.
And to get them to roll the dice and spend 300 million on a study is just not feasible. They've got to live or die by something in a shorter framework. And look, things like Raise Bio, that mentioned the actinium study and the neuroendocrines, people get excited about it, but they know that there's an end in sight. So then you can get a big pharma to come in and take you out. But yeah, you still have to have a time frame that is realistic in order to meet your endpoints, and a budget that is realistic to be able to fund it.
So I will jump in to close us out.
Thank you, Rick.
A big thank you to all the sponsors. but in particular Telix, because Telix encouraged us from the beginning to run a radionuclide webinar in 2023. We didn't quite get to it, almost. We were just a couple of weeks late, but we got it. And so it was some of their pushing. And in that regard, I also want to say a huge thank you to Kathy Russell at Cardinal, because without Kathy, we couldn't have gotten to Dr. Kuo. We might have been able to get to Dr. Sartor, but she was also helpful, very helpful with that. And so huge thank you to Kathy, and also for the help she gives us behind the scenes in supporting some of the guys when we try to find out where they, well, earlier in the day, certainly when we tried to find out where they could get screened. It's getting better now, a year later, than it was a year ago. And most of all, I want to thank the docs. Well, I want to thank our team. I should probably do that before the docs. I'd like to thank John and Dr. John and Ben and Len. Ben has been preparing for this webinar for probably over a year and is exceptionally knowledgeable. And Len is just a huge asset to me and to ANCAN since he was really diagnosed back in 2014. We've been working together. And then last of all, I really want to thank Dr. Kuo and Dr. Sartor. There will be sweatshirts coming your way, ANCAN sweatshirts. Alexa will talk to you about what sizes and colors you want and where to send them.
Like it's the ANCAN shirt fairy. It's not Alexa.
And hopefully you'll wear them occasionally with pride. Somebody told us they're perfect for when they go skiing. One of the doctors told us recently. We are truly grateful to you. But the bigger thing we're grateful to you, and I say this especially with Dr. Sartor, it's the access that we have on behalf of our patients to you, because there are times when that access, if nothing else, by telling them that, yes, we've talked to docs like Dr. Kuo and Dr. Sartor, that we reduce their anxiety by volumes, because they're not getting the information they want from their doctors. And if we can go behind the scenes and retain this access that we have to you, we're allowing you to do a huge amount of great work on a one-on-one basis. And we're very proud to be able to do that. So with that said,
let me just mention
everybody
something.
listening, come on into our meeting. Go ahead, Dr. John.
I just wanted to mention something about Dr. Sartor that the audience might not be aware of, but there are people in the audience who have responded to drugs like cabazitaxel, radium, leuprolide, and for your information, you have Dr. Sartor to thank for that response.
It's a pretty big team effort, I promise. It takes a lot of people to get a drug moving forward and getting approved, but I've been working at it a long time.
Yeah, almost 35 years, I think. Thank you.
That's it.
Great.
All right.
Thank you, everyone.
Bye, everyone.
Good night.
Thank you.
Pleasure.